So let's talk about our Chapman and DeLapp case study. Some background. Remember, there are like phobias with particular names. Agoraphobia is named in your ICD, but the ones that don't have those particular names are just referred to as specific phobia. So a phobia is an excessive and unreasonable fear triggered by the anticipation or presence of a specific object or situation. So BII, or blood injection injury specific phobia, is people who are fearful of exposure to blood or medical related procedures. Something about BII phobics that is unique that they found in research, not completely unique, is that they often experience very strong physiological responses, including fainting. So the way it works is almost everybody who has a phobia experiences that first step, that increased heart rate, or that increased blood pressure in like anticipation of encountering this scary item. But the people with BII phobia also seem to experience what they call a diphasic physiological response. So there's the increase in blood pressure, but then there's also a sudden decrease in blood pressure and heart rate. It's the latter part of that physiological response, that's called vasovagal syncope, that actually causes them to faint. The vasovagal refers to the vagus nerve. The vagus nerve is just part of your parasympathetic nervous system. You don't have to know that, but that is what is causing the dramatic sudden decrease in physiological arousal. Other research suggests that in addition, there is, and you should remember this from Savidra and Silverman, there's a strong disgust response that happens in BII phobia. BII phobia obviously isn't the only one in which people experience a disgust response, but strong disgust sensitivity elicits parasympathetic activity and reductions in blood pressure that influence fainting symptoms in BII phobics. So that disgust is tied to the parasympathetic activity, which is tied to the fainting. They mention it, so let's just make sure we're aware. There's two types of disgust that are relevant, that they've identified as relevant to phobias. One of them is called core disgust, or just a sense of vulnerability in being contaminated by a non-predatory animal. It seems very specific. The other one is animal reminder disgust, or an emotional dislike or repulsion to reminders of human animalness. And in this case, we're talking about blood or veins. So the fact that the blood that we're afraid of reminds us of the fact that we're all animals, that is the type of disgust that seems to be popping up most when it comes to BII phobia. Some studies already done found that there was a decline in the fear of the stimuli, but that decline was greater than for disgust. So it was easier to reduce the fear responses than it was to reduce the disgust responses to the stimuli following those repeated exposure techniques. So based on that, the researcher suggests that the extinction of disgust reactions may be more resistant to exposure therapy than fear responses. So this kind of ties us back to Savidra. Remember that same thing happened. So a crucial part then of this treatment may be also using cognitive behavioral therapy to address the disgust responses, not just to help them become desensitized to the fear. And the way you treat phobias obviously is cognitive behavioral therapy. You are doing cognitive behavioral therapy. Obviously, at the same time, what you're doing is exposure therapy. We call this systematic desensitization, systematically working through that fear hierarchy, desensitizing or removing the emotion, but you'll also hear it, he refers to it here as exposure therapy. I'm not going to read that to you, but I will remind you of how applied muscle tension therapy works. Obviously, it's hard to get your participant to work through their fear hierarchy when they are on the ground. So the thing that works alongside that is applied muscle tension. The way that works is to continually tense muscles throughout the body, thigh, stomach, arms, fists, jaw, for about 10 to 15 seconds, then followed by a 20 to 30 second muscle release, which is intended to prevent the excessively aroused or relaxed state. Because we don't want them because the heart rate will go up, but we don't want them excessively aroused, but then we don't want them to become too relaxed either, because that sharp fall off of blood pressure and heart rate is when the fainting happens. That allows them to counteract a sudden decrease in blood pressure and delay or prevent the onset of fainting sensations long enough for them to start habituating to that feared medical stimuli. A lot of the literature for this refers to, like, there have been a number of studies that look at applied muscle tension and CBT to treat BII phobics, but the researchers only found 5 RCTs that were conducted by the same research group. And in each different treatment approach, whether that's applied muscle tension plus CBT, CBT only, only applied muscle tension, each treatment approach demonstrated comparable improvements in about 70 to 80% of BII phobic subjects. But all of those had small sample sizes and had not yet been replicated. So into that steps Chapman and DeLapp with this case study. That's the idea was to allow them to more deeply understand the active mechanisms of change through the course of treatment. So how exactly did it work, at least for this particular subject? Here is the description of the subject. I'm not going to read it to you. You pause it and read it and remind yourself. One thing I would point out from the original study, which is significant to us, he self-referred himself because of the significant distress and impairment that he experienced as it relates to his 2 children. So remember we talked about Rose, the significant impairment to relationships, occupation, social life, education, whatever it is. So he self-reported because not being able to accompany his children to his child with autism spectrum disorder, not being able to accompany his children because of his phobia was one of the many things that was particularly a problem for him. These were the initial assessments that they completed. The Beck Anxiety Inventory, obviously, the BDI, and then they also had him take the Q-less-Q, which I'm going to have you look at in a second, something called the Fear Survey Schedule 2, and then the Blood Injection Symptom Scale. They also, of course, did a clinical interview, which we all know what that is. Take a look for a sec at here is the Q-less-Q. This questionnaire is designed to help assess the degree of enjoyment and satisfaction experienced during the past week. So this is kind of like the Sheehan disability scale that we looked at before. This is kind of an overarching, like, how well are things going? You can see that there's a section for physical health and activities, where how much of the time have you done these things? All of these are positive notice. There's another section for work, if you have work, and then you can see all of these things are fairly positive, are all positive related to your work, and they're all kind of how often. These are on a 5-point scale. Household duties, are you staying on top of your household duties without stress? If you're in school, as far as your school and your coursework, what about your leisure time activities? How often are you doing those things and they're like making you happy, you're enjoying your life, your social relations, your general activities? So you can see that something like this isn't tied to any disorder at all, but it is a good measure of how your disorder might be affecting your life, and then you could use this as a measure of how treatment of your disorder could be improving your life. Another one is they use the BIS with him, the Blood Injection Symptom Scale, not the BIPI. This is 17 items, and you will see that they are, sorry, I had to sneeze. They're yes or no. So you can just take a look at those. So this is, you can see these questions ask about sensations you may experience in situations involving blood or injections. There are, of course, physiological responses here. There are also some cognitive responses here. I don't see. So I was looking for conscious behavioral responses. Because remember, in the BIPI, you've got your cognitive. I thought I was going to die. You've got your physiological. My heart was racing, and you've got your behavioral. I left, or I changed directions. Whatever it is. This one, this BIS scale is a little bit simpler. I don't expect that they'll ask you in specific detail about these individual measures that they used, but I didn't want you to not see them at all. They do tell us that the BIS 17-item self-report questionnaire assesses the sensations experienced during situations involving blood or injections. The internal consistency for the BIS in the original study was adequate at 0.86. The validity was obtained from a factor analysis with no other studies to date examining its validity. So through that clinical interview, they found that T did meet the diagnosis for BII phobia. He also had recurrent depressive disorder that was at the time in remission. He also demonstrated some characteristics of panic disorder, but that was exclusively in the context of medical procedures, so it all fit into his BII phobia. By the way, shout out to Beck at least for having his Beck anxiety inventory also be 21 questions on a 3-point scale. He is real for that at least. So I was gonna just scroll through this and let you see how that gets calculated. And it's similar, it's a 0 to 3, and then the measures are a little bit different. I should say it's not like a I never feel this or I always feel this, but you can see it often, it does kind of go to mildly, moderately, and severely. So this section, Chapman and DeLapp call the case conceptualization. They are kind of explaining what has brought T to this point, but for us, it's a great review of our explanations. Multiple vulnerabilities have interacted to facilitate T's perception that medical procedures and blood are dangerous. A generalized biological vulnerability, including familial transmission of anxiety, in concert with a number of distinct learning experiences cause T to associate fear, anxiety, and death with blood medical contexts. There is what he calls an inherited tendency to experience vasovagal syncope. We know that these phobias that cause these strong physiological responses are more likely to be inherited. And then that made him vulnerable to the development of all of these behavioral causes. He had all of these early learning experiences that caused him to associate fear, anxiety, and death with these medical contexts. His mother modeled those avoidance behaviors, and then he also practices them. So he maintains his phobia by reneging on scheduled appointments, thus temporarily relieving his anxiety about medical procedures. So remember, negative refers to the removal of something. So he cancels the appointment, and as a result, he feels that relief, and then that reinforces the behavior of canceling the appointment and continues to reinforce the phobia. He also, they tell us, engages in an intense exercise routine that includes running, biking, weight training, and swimming, all of which are other indirect avoidance strategies for doctors that also, they allow him to feel like he's in control, but we know, of course, he's not. He feels intense shame about not being able to be there with his kids. So they tell us that T heard about cognitive behavioral therapy on the internet, which is why he came seeking it. This is something called, it's in the title of the study, it's something called manualized cognitive behavioral therapy. And I looked that up and then I was like, oh, of course. It means the therapist used a manual. They used this one was called Mastering Your Fears and Phobias. It's an actual book, and the therapist follows the instructions in the book. But to get an idea of his course of treatment, in session 1, they started by talking about how he acquired his fear, beginning that psychoeducation, making sure he knew that this was how common this was. They talked to him about the role of the vagus nerve and how that relates to fainting. And then they discussed the costs and benefits of treatment from a CBT perspective. They also, in those first few sessions, they introduced some of the forms that are associated with that particular manualized therapy. One of them is the phobic objects and sensations form. That is one where the patient will put a check mark next to the objects or situations that he fears and numerically rank orders each one. So you can see how that would be the first steps to starting to create that fear hierarchy. He also was given a thought record to record what he was thinking, obviously, and an avoidance and coping strategies form. Finally, he was also given a phobic encounter record, which he was supposed to do for homework, and you fill one of those out whenever you encounter your phobia. And then you're ranking your fear of the phobia or the phobic object or situation from a 0 to 100-point scale, and you're describing any bodily sensations that you experienced. So there's a lot of homework involved in this kind of therapy, like with many of ours. And so patients have to do the work of recording that stuff so that they can share it with their therapist. In session 3, In session 3, he reported no encounters with his feared objects or situations during the previous week. So unsurprisingly, he's still engaging in avoidance. But on both session 2 and 3 and 4, he reports feeling optimistic about the experience and about the prospect of treatment. In session 3 is when they start actually introducing the rationale for cognitive restructuring, how it works, that we're identifying the misinformation and misinterpretation of situations, objects, and bodily sensations. And they describe to him those errors in thinking, catastrophizing, jumping to conclusions. It's a great example of how CBT and like thinking errors occur in almost every type of disorder. But while the thinking errors we're identifying and challenging in schizophrenia are very different than the ones we're identifying in depression. What catastrophizing looks like in depression is very different than what catastrophizing and jumping to conclusions looks like for phobias. The key principle that was described to T was the notion of remaining in a situation with the phobic object or situation long enough to facilitate new learning. And that's what exposure therapy is, getting them to stay in that moment long enough that they can learn and realize I will not die, which again, connect that to exposure and response therapy for OCD and the idea of habituation. Another thing that they taught him in session 3 was treating thoughts as hypotheses rather than concrete facts, which makes a lot of sense because if what you're dealing with as in all of these disorders is thinking errors, then you need to train people to think not all my thoughts are concrete fact. In depression, when I say no one cares about me, no one would miss me if I was gone, I have to go, that is a thought, that is a hypothesis, let me test it. That is not necessarily a concrete fact. So challenging and disputing those thoughts is at the heart of CBT, no matter what you're using it for. Come session 4, they collaboratively created his fear hierarchy, which I'm going to show you on the next slide. They explained to him what a SUDS was, the subjective unit of discomfort scale. And then they talked about how we need to take these old associations and replace them with these new ones. Session 4 was when he told them that he felt optimistic and he had even gone and bought a blood pressure cuff and a heart rate monitor to get ready for these phobic encounters. So although he had not, and he didn't have to fill out a phobic encounter record, you can see that he's feeling like hopeful and he's like taking positive steps towards improvement. Some of them, they talked about myths of exposure therapy here. And one of them was emphasizing the insufficient duration of remaining in the situations and lack of cognitive restructuring during previous exposures. Because you can see how this would not work. Just forcing somebody to encounter their phobic stimuli and not giving them any coping skills or cognitive restructuring skills, and then they're going to eventually, like, even if you can make them stay for a minute next to blood, they're going to flee it. And that's not going to change anything. They don't stay long enough to learn that it's okay. And they're so anxious that no learning can happen when you're physiologically so heightened and anxious. So that's what they talked about, was how like this has to follow a very particular pattern in order for exposure therapy to work. So here's his exposure hierarchy as a reminder. Remember, they've asked you to know particular items before. I'll let you read kind of the description of what he did at his other course, at his other things, and then we'll take a look at his final results and talk about a few applications. His BAI goes from 41 to 7. Perhaps more importantly, maybe his BIS, his blood injection symptom scale. Remember, there were 17 questions on it, and pre-treatment, he reported experiencing all of them, though that was the yes/no one. He experienced reporting all 17. After treatment, at the 12-month follow-up, he said he only experienced 4 sensations from the BIS still, feeling anxious, heart pounding, feeling nauseous, and sweating. He was still experiencing those during exposure to medical-related stimuli, but he repeatedly stated how thanked the therapist, said how much better he was feeling. Chapman and DeLapp repeatedly emphasized that this kind of treatment can lead to an increased sense of self-efficacy and allow them to actually do new learning. Chapman and DeLapp mentioned that the collaborative nature of the treatment may facilitate treatment adherence. Because you're seen as working together with the therapist, you're more likely to adhere or do the treatment than if the therapist told you what to do, because it's collaborative. That graduated nature of exposure is also important because they start to feel that small initial success, and it bolsters that sense of self-efficacy. The other thing I wanted to point out to you from the discussion, there's a section where the last section of the study is called recommendations to clinicians and students. So like, it's just like a summary of what we've learned and what we think is important. Oh, I'm sorry. I was going to mention, they have this section where they're like, there were some unique things about T. In addition, they say T was generally behaviorally inhibited and experienced considerable social anxiety, as evidenced by his anxiety at the barbershop. Like for some reason in an earlier session, he described how he was at the barbershop and everybody was looking at him. And he described it in the context of like a time he felt anxiety. But the researcher like clocked that and was like, also he's socially anxious. He also he reported some symptoms of OCD. Although during that initial clinical interview, they found that his symptoms were subclinical in nature. But they say, nonetheless, T appears to be prone to obsessive thinking when under significant distress and anxiety. So those are just some, and they also mentioned how in addition to his like blood phobia, he has anxiety about other medical procedures that are non-invasive that don't cause the syncope. And he has these panic attacks, these situationally bound panic attacks that led to the need for more CBT. So they just wanted to like be open and be like, here's some areas in which T is unique, some complicating factors. But in the recommendations to clinicians, they praise the structured manualized approach, but they also say that it is important to make sure that that treatment is individualized and that you remain flexible when you're using those manualized treatment approaches to to individualize certain treatment ingredients of the MYFP, that protocol, in order to make sure to tailor it to the particular patient's fears and phobias to make sure that it's like working for them. Another recommendation they make, which seems salient to us, is make sure that you're maintaining empirical data throughout treatment to quantify patient progress. Make sure that you have that BAI, that you're giving them those regular check-ins so that you have that quantitative data that you can point to and say, see, here's how the improvement is happening. Obviously the SUDS was collected constantly. That's why on that set of things, you have like all of the ways that his SUDS decreased. You don't need to memorize those, but making sure you're collecting quantitative data is crucial. One of the impressive things about this is they did it in 9 sessions. That in 9 sessions, they were able to through that Mastering Your Fears and Phobias manual, they were able to take him from this kind of crippling anxiety and fear to never feeling better in his life. You can take a look at these strengths. Think about why blood phobia is so important to cure, or BII phobia is so important to cure, particularly like injection. Like you can avoid dogs. You can, and it won't necessarily decrease your quality of life. But like if you are avoiding standard medical procedures, vaccinations, blood draws, all of those things are going to they're going to cause problems because you're not going to be able to diagnose or get these early interventions, and that's ultimately going to be costly. You can take a look at the weaknesses. They're the same kind of standard weaknesses of any case study. Hopefully that helped you remember the important parts of Chapman and DeLapp.